Well, today we're going to be talking about how leadership influences people to make changes and get desired results. So, kind of about leadership, clinical and operational leadership, how we manage together in the pandemic in the nursing homes. COVID-19 prevention and management requires more than the clinical team. It calls upon others, such as the environmental services, to clean and disinfect. So it's everybody working together. And how can we be adequate leaders in such a situation? Next slide. How leaders need, in order to be a good leader, we need to be vigilant about the emotional stress that this kind of pandemic has placed on everybody who works for us. And in the nursing home specifically. And we need to model supportive behavior through our servant leadership. And one way to do this effectively is to certainly break down hierarchies. So everybody on the team is respected and valued for what they bring into the nursing home setting. So I think we have, oh man, that's blurry. There we go. And this is a video, so I'll be quiet now.
Hello, this is David Farrell, and thanks so much for joining this ECHO session. So appreciative to take some time with you to talk about the QAPI aspects of leadership during COVID-19. Let's get started. So as you all know, the QAPI requirement of nursing home encompasses these 5 specific domains: design and scope, government and leadership, feedback, data and monitoring, performance improvement projects, and systematic analysis and action. For the 20 minutes that I have with you, I want to encourage you, number 1, to keep your QAPI steering committee alive and active during this pandemic. After all, there are plenty of performance improvement projects to engage in as it relates to COVID prevention and mitigation. But primarily today, I want to focus on number 3 and number 4 on this visual, and talk specifically about data measurement and acting on it. So here are 3 specific buckets, if you will, related to COVID data. And I want to speak a little bit about each one of them. The first bucket is your structural measures of quality. And the structural measures of quality that your QAPI steering committee should be tuning into are the structural measures that measure the nursing home's organizational capacity to prevent and handle an outbreak. Next are your process measures, or your COVID process measures. Process measures measure the performance necessary to prevent the virus from getting in, containing it if it does, and to care for those who test positive and negative. And then finally, the COVID outcome measures are the ones that we read about in the news and the ones that tend to get the most attention. And of course, those COVID outcome measures include the number of positive cases, the number of deaths, and the number of people who have recovered. So let's dive into each one, starting with structural measures of quality under COVID-19. So here's some examples of some structural measures which really predict the nursing home's organizational capacity to keep COVID out or mitigate the spread if it gets in. And of course, some of those structural measures include staffing, your total number of hours per day, the total number of nursing hours per day, your total number of RN hours per day. Another structural measure would be, do you have a full-time RN who's in the role of infection preventionist? And other structural measures would include the number of vacant positions you have in your nursing department, the number of shifts worked by agency staff to fill those shifts, and the number of shifts that are understaffed. Additional structural measures which measure your organizational capacity would include your days of PPE on hand, your environmental capacity to cohort. In other words, do you have empty private rooms with private bathrooms? And also, do you have a contract in place with a reliable lab that will deliver timely results? Critically important as a structural measure of quality during COVID-19. Some of the process measures to consider, and remember, process measures are the measures of things that your organization needs to be doing to keep COVID out or prevent the spread if it gets in. And some examples of those include the percentage of people entering the skilled nursing facility that are properly screened or not, the percentage of staff who completed competency testing, hand washing, donning and doffing PPE, all the competence tests associated with COVID. What's the percentage of staff who completed those competency tests? What's the percentage of consistently assigned staff that are consistently assigned to certain designated zones or wings? What's the percentage of staff still working two jobs and potentially bringing the virus in from another nursing home? Have we completed our weekly assessment of preparedness? Do we have a score that we're monitoring every single week? What's the percentage of advanced system surveillance checks that we've completed? In other words, if we're checking for symptoms in our residents every 4 hours, let's audit to see if that process is actually in place. And of course, what's the percentage of staff and residents tested this week? If we know that screening testing is our best defense, how many folks were actually screened this week? So here's some examples of the things that, measures of the things we have to do consistently to keep COVID out or and from preventing its spread. And then some examples of outcome measures under COVID include these: your coronavirus test positivity rate, both for residents and staff, the percentage of positive residents and staff who've recovered, your census in the red zone, is it increasing, is it decreasing, the number of hospitalizations, the number of deaths, the Department of Health-focused infection control inspection results, how many deficiencies did we get? Were we deficiency-free or not? Other clinical outcomes, we know that we need these balancing measures, if you will, to determine if pressure sores are going up or falls are going up as a result of our keen focus only on COVID. So we want to look at other clinical outcomes. And then, of course, grievances from residents or families or that have been sent to the ombudsman. These are good measures of outcome measures related to COVID. So then, of course, we can show staff some visuals of some of our outcome measures to get them excited about trends that might be going down related to new hospitalizations or the positivity rate. So we're measuring or testing our residents and staff aggressively, but lo and behold, our positivity rate is going down. There's a good trend. And here's an example of a process measure, the percentage of staff properly screened before clocking in. As you can see, back in March, we weren't doing so well, but as we've implemented a performance improvement project, as you can see, we're getting much better compliance in July than we did in March. So there's other key variables related to the size of outbreaks in nursing homes that we want to be mindful of. And this, of course, this is all based on the literature. If you're a larger facility, then you certainly that would be a variable that would leave you more vulnerable. If you're primarily serving people on Medicaid who are either Black or Latino, that seems to be a variability that researchers have noted that leads to larger outbreaks. If your nursing home is located in a lower income zip code, if it has a low star rating, if it has a low star rating for RN hours and total nursing hours, these are all predictors of outbreaks that could get bad. If you don't have an infection preventionist on staff, or there were numerous deficiencies on the targeted infection control survey, would be another key variable related to the potential for a large outbreak. So your QAPI steering committee should really be focusing on metrics, measures, the structural measures of quality, the process measures of quality, and the outcome measures of quality under COVID. So the QAPI steering committee, really has to identify based on all those metrics what the priority should be. And so they really need to have a fairly formal method of prioritization related to all these data points and what to tackle. And of course, they should reflect on scope and severity of the problem that they're looking at. They should consider the impact of what they choose to tackle, but consider the impact on residents, families, staff, customers, and then they need to assign performance improvement projects based on that strict adherence to prioritization of problems. They really must ensure that staff are engaged in the root cause analysis and that they're hearing from CNAs and housekeepers about the gaps in systems if they expect to really identify effective solutions. So it's super important that performance improvement projects are assigned by the steering committee, but the team itself is made up of a multidisciplinary group that would include housekeepers, CNAs, nurses, and some other department heads. This is a concentrated effort on a specific problem. For example, we're scoring low on the percentage of staff that are properly screened before their shift. That's a very serious issue. That's a priority for us to fix. Let's start measuring it. Let's test some solutions. So let's get to it and carry out the PIP. So that group does the root cause analysis. That group identifies changes for improvements, tests those changes, and reports the results back to the QAPI steering committee. Nothing's more important than the root cause analysis. Nothing's more important than a leader facilitating a meeting with frontline staff and hearing from them why 15% of all staff are not properly screened. Oftentimes our problems are complex, and really a root cause analysis should be called a root causes analysis, because very rarely is it just one thing that leads to only 15% of staff are not properly screened. So a root cause analysis, you really want to have the right paradigm. Good administrators and DONs really should consider that their frontline staff know more than they do, and they need to be humble enough to create a forum to hear from them specifically what's contributing to the problem. You need their buy-in into the solutions, and you're much more likely to get their cooperation and buy-in if they engaged in a root cause analysis with you and helped you identify the real issues that are at the heart of the problem. So make sure the right stakeholders are involved when you do a root cause analysis, and you'll have a much easier time implementing a solution. So PIP work groups test changes to fix the root causes. They plan what to change, they carry out the change, they determine if it worked, they tweak it to make it even better, they carried out a refined change, they determine if it worked. If it did, they go to the steering committee, hey, we got a successful PIP here, we should spread it throughout the entire nursing home. And the steering committee implements a plan to spread the good idea to the other units. And remember, small changes matter. They don't need to be big. Berwick said, if you can't change something big, change something small, and change another small thing and another small thing. And sure enough, that will add up to a solution. QAPIs are really important during COVID-19, and the involvement of your medical director and DON and frontline staff in meaningful PIPs associated with COVID is critical to prevent the next outbreak. QAPI is really an effective tool for leadership. It certainly has enhanced my competence as a leader by following the QAPI principles. QAPI promotes a collaborative effort. It makes problem solving interesting. It triggers me to always include frontline staff and include them on the front end of identifying problems. It keeps me humble. It forces me to listen. But most of all, QAPI will help you improve outcomes and save lives during this pandemic. QAPI triggers staff to want to try harder. It triggers the discretionary effort that we're all hoping for during this pandemic. Staff need to be making that discretionary effort to keep COVID out and mitigate its spread if it gets in. So employees are engaged when we're engaged. If leaders are engaged and optimistic, if leaders understand their role, if leaders over-communicate, if we try to foster trust, if we make people feel valued, people are engaged and mirror the leader. And so I know you're probably wearing down because it's 6 months into the pandemic, but just remember, staff will mirror you. So try to stay engaged and your staff will be responding in kind. Balance. Balance performance with compassion. The best leaders get good performance from their people every shift, but they get it through compassion, not through being directive. So make sure that staff can feel and see and hear your compassion, and when they do, they're much more likely to perform. That concludes my ECHO session. I thank you so much for tuning in. I wish you best.
All right. I'm not sure if Kelly, are you taking over this part?
Yes, ma'am.
All right.
Thank you.
Can I just intervene here just for a quick reflection as I was reviewing this video. One of the outcomes that they listed was, the percent of people that recovered from a COVID infection. And while that is an important metric, I think it's also important for us as kind of a root cause analysis to understand that the emerging data of the pandemic is showing that up to 25% of COVID recovered patients have the long haul COVID syndrome. And we don't know this in long-term care. I've not seen any, I don't know, Dr. Dahl, if you've seen any reports. I certainly have not. And this actually may be a good opportunity for facilities collectively to try to understand the post-COVID syndrome. So for me, quite honestly, while it might be a celebratory, metric, is all of our 100-year-olds that survived the COVID pandemic. So we know that 20% of 80-year-olds with COVID succumbed to it. It's the highest percentage of any infection ever. And so it's been very dramatic. However, for those that have survived, we don't know exactly how much they're recovering. And implicit in that conversation that we had with Mr. Farrell was that there might be more falls, there might be more decubitus ulcers. These are all values or assessments that we would need to do to see if the pandemic really has had a substantial impact on other quality metrics. But I think it's important to consider functional recovery. And so, on the MDS, is it an opportunity, even though you may not be required to do that, reassessment? Certainly you have to do a reassessment when the resident comes back from the hospital, but for those that stayed at the facility, they had a change in status. Did you do an MDS reassessment? And if you compared their functionality, do they require a higher functional assistance than pre-COVID? And just getting those metrics as a root cause analysis will also help you understand what the status is of the facility and the needs for addressing functional impairment. So I just wanted to add that commentary. So sorry for interrupting there, Kelly.
Sorry, no, you're good. You're good. I did want to touch base real quick on our initial poll on the last question. We talked about the root cause analysis tools, and the spaghetti diagram or the spaghetti chart, as well as the process, I think it's called a process chart. Both of those can be used to evaluate your process to determine efficiency. And so you may be able to identify your root cause or your area of improvement or opportunity to improve by utilizing those tools. But if you think about a spaghetti diagram, if you're familiar with it in say a manufacturing plant, when you're going through the production process, you can do it multiple different ways and then see which one is most efficient. And so that's hence spaghetti, because it looks like a bunch of pieces of spaghetti on a chart. And then the process map is really it's almost like a flow chart or a flow diagram. So if you realize, you know what, the CNAs during their rounding process, it's taking a lot more time than what we anticipate it to, or what we had thought it would, then you could plot it out on a flow chart or a process map, and then look and see how many steps they're taking. Is there a more efficient way to do that? But I just wanted to throw that out there. Those are two that really evaluate your processes whenever you're going through a system. And when you're doing the root cause analysis, you're really looking at a bunch of different ideas of why there was a failure or why there was potentially a failure. So just wanted to throw that out. Notice that at the very end. Okay, we will go ahead and get started. You can go to the first slide there for me. I just want to briefly overview kind of what we talked about over the past 15 weeks. And I've highlighted a few bullets on this slide that I feel like, or that are in my opinion, are really keys to success whenever you're looking at quality improvement. I think they're quick things that you can do on a continuous basis. The first one is psychological PPE. I know I've showed you guys that one pager probably half a dozen times since we've gone through this series, but the reason I want to reinforce it and reiterate it is because if we can't take care of ourselves, it's very hard to take care of the patients. And so we have to remember that the staff and the leadership within the facility have to take consideration to take their time off, take that breather in order to be at top notch for the residents. Number two is the RCAs that we talked about earlier. And if you can't get to the root cause of what an issue is, then whatever steps you put in place or whatever interventions you put in place are not going to be successful. So it's really important that you really dig deep and find that out. Just as I mentioned in those more process-oriented tools, is that you can go through the process and determine where that piece is that's missing. So I think it's very important. And the reason I touch on these is we didn't really talk about these that much during this series. So I want to make sure that you can understand the difference when you need to use one of the process analysis tools opposed to the root causes. Testing the 5 attributes, the questions I bring up all the time: who, when, where, what, and how. Asking 5 staff those questions to determine the reliability of a process that you have put in place. They are the closest to the opportunities that may arise, and so you really need to utilize them to find out how those systems are working. And last but not least, it's rounding to identify opportunities. The best way to recognize an opportunity is to see it with your own eyes. And the best way to build a relationship with your staff and maintain that positive culture in your facility is to be present with the staff and that's during rounding. And the best way to determine the reliability of your systems is to see it in action. So you go back to those 5 attributes that you can do during your rounding process. Okay, we can go to the next slide. Now, I know that COVID has kind of turned everything upside down. And as the leadership in the facilities, I think this is really giving you an opportunity to highlight some of the good things that you've learned and overcome through this process. And so on this slide, I've just listed a few like reflective questions for you all to take back and think about, what did I do differently during this pandemic? What was successful? What was not successful? And how can I incorporate that into a continuous quality improvement within my facility? The first question I have here is on frustration. And so I understand with the ever-changing guidelines that have come out, I'm sure there is frustration there, short staffing, frustration. How did you overcome that and how did you deal with that? As the leader in your facility, I'm sure that you've been able to adjust and adapt. And those traits that you've learned through that process would be a great opportunity to share with your other leadership team. And so they can carry on those same traits. If you're overwhelmed, how did you address that? How did you deal with it personally? So then you can provide those traits and those key points to your line staff. The line staff is working probably short or challenged. I think it's the term I used to use all the time. We're staffing challenged. And so how do you teach them some time management techniques to make sure they still get everything done during the day, or whatever system that you put in place for yourself that was easier for you? What did you learn about yourself as a leader, good or bad? And how can you turn that around into a positive and for continuous quality improvement? And similarly, best practices. What did you find that was most beneficial that you did through this process? Did you become more transparent, calm, resourceful for your staff? Were you more present in their day-to-day operations? And as always, when you determine these opportunities or you identify opportunities, then you always can translate those into a performance improvement project or a performance improvement plan. And for example, could you conduct trainings on managing stress? Maybe there was something, maybe you picked up yoga during the pandemic because that was some kind of stress reliever. Find something that would be helpful for the staff and try to translate that into a PIP. Next slide. And as I mentioned before, COVID-19 has definitely taken a toll on all of you that are in the front lines there, but you are all heroes, and thank you for keeping your ship sailing. I just pulled this quote from online, but I thought it was a good representation of what you all have been through over the past year. And I really appreciate all your hard work, because it takes people like you to keep us moving and going in the right direction. And I'll read the quote: "A hero is an ordinary individual who finds the strength to persevere and endure in spite of the overwhelming obstacles." And I'm sure you all can attest there have been some overwhelming obstacles over the past year. Now, one of the videos that was the setup, you can go to the next slide, sorry. One of the videos that was set up for the for this session, and I'm not sure if we can share it after the call, Julie or Sarah. It was a little bit longer. It was the same gentleman that presented on it. Some of the key points he presented are right here. Some best practices in quality improvement. We've talked about rounding continuously, and if you're making rounds and you're observing things, you have to make sure that you follow up on those. And so you need to take notes whenever you're rounding, so you can follow up and see what those processes are. Huddles are a great opportunity to be present with your staff, as I mentioned before, and have those conversations to get input and feedback from the staff in real time to help inform some of these performance improvement projects. And, you know, if you haven't incorporated huddles into your normal practice, how would you implement huddles? And why would huddles be an opportunity? So if your root cause was we've had very poor communication, or say you had a resident who had multiple complaints over a missed care task, and it was because she needed to be toileted every 45 minutes opposed to the normal every 2 hours. And so you had all of these complaints come in about this. What is a way to address that? Well, if the staff were having that huddle at change of shift, that may be an opportunity they could have those conversations and that wouldn't be missed. So that's where your issue was identified, is through those complaints. And it was poor communication, and that's the result. But you'll talk to the staff and see what they think the best option is to put in place. But that's just an example of where huddles, I think, would be a good intervention if you don't already have something like that in place. And I think we have one more slide, and this is just an idea of some of the copy boards that have been used with quality improvement. And it's a good idea to have these things posted and present for staff to understand what it is that you're doing and how you're improving, and how their participation is assisting in reaching your goal or your vision, your mission as a facility. This is our last session. Thank you all for letting me talk to you for the past 16 weeks about quality improvement. I hope that some of the information that we have provided, or all the information, has been helpful. And we look forward to hopefully working with you guys in the future through the phase 2. So just last time, remember that all opportunities can be turned into performance improvement. So really kind of take a look at that as you're making your rounds and visiting with staff.
That's great. Before we get to the summary, I just wanted to ask if our participants could put in the chat box whether they had, after our session with the wellness for staff wellness, whether they adopted any of the recommendations. It could just be a yes, we did this, if you could put in the chat box. So for example, we were asking if anybody did a celebration board on a unit as an example. So yeah, thanks. So Carlos, yeah, you're already using many of those techniques. We talked about gift cards and rewards, time off. Has anybody used extra time off, for example?
No one's willing to put in their
They're the
2 cents.
welfare, yeah.
I think, did we talk about how we put up a board in our clinic here, and been 1 week at a time, we're just writing things that we like about different members of our staff. I think we had talked about that the other day.
Yeah. We're posting on the board, things. Photographs are always wonderful too. One of the things that can be helpful is using photographs to actually look for quality improvement. So just as a reminder, in professional baseball, when they show videos of a baseball player swinging at the ball and hitting a home run, showing perfect form, that individual will hit another home run later. But if they show him striking out, generally he'll strike out next time too. So those videos, those visual imageries really can help promote positive attitudes. Yeah. So we've got a few more people responding here. I guess it's part of our little bit of delay here with the better weather coming into the Dakotas. So I like that one about the employee of the week. That's really wonderful. Catching somebody and doing something good. Yeah, for the residents, and obviously act and perform in the best interest. Yeah, that Steve got a really excellent point. It's because a lot of it's always setting up expectations. And so I think just, to reflect on what you're saying is that the idea of intermittent reinforcement and mixing it up and knowing that there are moments of rewards, and it could be just verbal rewards. It doesn't have to be monetary. It doesn't have to be presence. It could be maybe simply a written card of thank you from leadership. Certainly I know this to be true in our program at the University of North Dakota, that, for example, we have speakers a lot of times, and the tradition is to provide a stipend, a monetary stipend, but actually we created a notebook for our speakers, and as a token gesture of appreciation, we gave them or give them a leather-bound notebook, for considerations. So yeah, so I think we're all in agreement, right? That that performing well and acknowledging that in some fashion is really important, and that's important for the culture, and setting up the expectations for the staff. I don't know, Kelly or Dr. Dahl, do you have any additional comments about that?
No, I definitely believe that recognition of performance it really is probably a better process to get staff on board, because most of them, yes, they enjoy those little gift cards, and they enjoy the food when you're serving food and such, but just the act of recognition, individual recognition, is very powerful for those folks. And I found when I was in the facility, the more I involved the line staff in day-to-day operation things, the harder they worked to do the right thing, because they felt that empowerment to do other things, and the opportunity to grow within the organization. Hey, if you know these things, then you have more opportunity to grow.
I agree. I think people like to be recognized for working hard, so you should give that to them. So that helps them to continue to work hard, and it gives the ideas of the people who aren't, maybe I should, right? They get recognized for that. So I think there's nothing wrong with letting people know when they're doing a good job.
Yeah, I was just going
to add one thing. Sorry, Dr. Jurevich. I just wanted to add, also kind of as a leader, myself, when I was in facilities, keeping track a little bit of sometimes those quieter people that aren't right in your face all the time. They get a lot of recognition, but there's a lot of hardworking people in the background that are very quietly going about their work. And so being very conscious about checking in with everybody and recognizing some of those people that aren't always standout productioners, if that makes sense.
Yeah, no, it makes perfect sense, because there are different types of people, and we've reviewed this in terms of our QAPI, that there's that bell-shaped curve of early adopters, midline adopters, and then what we call slackards, people that'll never adopt anything. So there's that continuum. So we have to recognize all those different groups of people. And then also to get back to Stephen Smith's point, is that sometimes careful what you wish for. So you have to think these reward systems out. When I was running a geriatrics clinic in Chicago, I told one of the med techs that if she helped us with this particular geriatric procedure, which is quite involved, it was video nystagmography. People had to put goggles on. And I said, they're going to give you a pay raise. I guarantee it. And apparently I didn't have as much influence on the pay raise as I thought I did. And secondly, I soon discovered that all the med techs were unionized. And so I had to go through collective bargaining to provide any rewards whatsoever. So again, you have to know the culture. And so Steve, thank you so much for that comment.
Yeah, Dr. Jurevich, if I can just add something similar to that. When I was, one of the biggest challenges I had with, Carla put, providing those gift cards for the extra shifts. I mean, sometimes that's what you have to do when you are challenged with staffing. to get them. But the problem is then whenever you quit providing them, then people quit picking up those extra shifts. So it's kind of it's a double-edged sword there to get them to cooperate or to be helpful the whole time.
Yeah. Yeah. So, I mean, again, a great illustration, Steve, you know, for helping us out with that observation. So I'm going to hand it back off to you, Dr. Dahl.
Sure. Go ahead, next slide. So just kind of an overview of all the things we've gone through over the past 15 weeks. You know, we've kind of seen a similar slide in Kelly's topic, but in Kelly's presentation. But in addition to the QAPI stuff, you know, we've learned a little bit about COVID and its different symptoms in the older adult and all of those kinds of fun things to look out for, and hopefully educated just on COVID as well. But these are all kind of the PIP stuff Kelly talked about. Next slide. So this next, is this when we're doing the waterfall thing, or is that the next slide? Okay.
The waterfall comes at the end of this slide deck. Yeah, thanks for asking.
Yeah. So suggestions that we've learned, asking people and staff what matters to you in your daily work, how to engage people and to keep spirits uplifted, what helps make a good day when we're at our best, what does that look like, what gets in the way of a good day. This helps with communication, with knowing what's going on at all levels, and how can we help people enjoy their work. Next slide. Use a framework to guide your PIPs, the PDSA cycles, models for improvement. Next slide. So this is kind of about, you know, don't go for the big things first. We can do the little small changes and have big goals out there, but always attainable goals. Don't shortcut identifying goals, aims, and measures. Use your tools to identify the right goal to go after, the right area for improvement. Make sure you're engaging your staff so that you can get down to the right things to change, or the things that need improvement, right? Families are also good to engage, and we've talked about that in several of our sessions. Consider using a small test for any new big idea being introduced. So start small and then you can expand, right? And then always bring people together and make sure you're following up. What did that change? Did that accomplish what we wanted it to? Did it cause other problems, and so forth? And like we've talked about multiple times, we got to communicate and celebrate our achievements, so everybody can you know, take pride in the things that have gone right. All right, so here's a waterfall. If you're group 1, your first initial of your last name is A through M. Group 2, first initial of your last name is N through Z. So we have one question coming up in the slides. The one group, you're going to answer, but don't put the answer out there or send it until we tell you to. And then the second group will type in what resonates most with them, and they don't press send until we recommend you to do so as well. Okay, does that make sense? I don't know if I made that clear. So group 1, you will answer this as soon as we say hit, but you can start chatting in what has been most helpful from our 16 weeks together. So how community aspect, a specific topic or moment or something you learned or something that just really has sat with you and made you change what you've done. So we'll give you a moment to type it in there. And we'll let you send that out. And so the second group here should be reading through these, and we want you to develop a response back into something that's came up here that you identify with. So we got new PIP ideas, PIPs, communicating info about atypical presentations of COVID, hearing others' experiences, how they are handling it, listening to other facilities' problems. They have faced in different ideas to how to improve upon them, getting new ideas from other facilities. Tips on the psychosocial needs of both residents and staff was most beneficial. How other facilities are handling situations. That seems to be a common theme. Next slide on our. Oh, so we wanted the second one to be the group 2 responding, right? To these people's questions. Yeah, so we'll do that first. If anything you identified with here.
And I just want to share something. I see a lot of you saying on here, you know, sharing ideas and with other facilities and such. One facility I worked at in a smaller community, there were 5 nursing facilities in the community. And as administrators, we all came together on a monthly basis and we all went to lunch together. Now I know with COVID that may not be as easy, but we all went to lunch together and it was just an opportunity to talk about some things that were going on within the industry, how we were addressing it, how we were dealing with it, and sharing with our peers and learning from each other. So just a thought, if it's something that's possible, if you all are in a close area, you could do something similar, just in a smaller group.
Yeah, I'd also add, Kelly, that some of the feedback that we're getting here is, I think, going to be very informative for phase 2 of this EchoCan program, so that we can expand and develop these ideas a little bit further, particularly with the psychological elements that we're talking about, and really to recognize the psychological elements for residents, staff, and family members, and maybe to a lesser extent vendors. But you know, I guess you don't always want to tick off the food man. You know, you never know what might happen. I was always told as I was going through medical school to never anger a secretary, because they can make life heck for you for quite a while if you ever need your medical school transcripts or whatever. So always be very nice to secretaries. So it was kind of bad, but that was the truth.
I agree with Vicky's here. Seeing that everybody has similar issues, it's nice to know that you're not alone and that there are people to reach out to and get other ideas from a different perspective. So I think that's a big one. We can go on to the next slide here. All right, so the second group, you're going to respond first, and then we'll have the first group comment in. So chat in your response to this question. What questions still remain for you in responding to the COVID-19 pandemic within your facility? So go ahead and answer those now. I would think now it's more, what do we do when everybody's vaccinated? How can we open up? What's a safe way to kind of go about opening up, and how aggressive can we be?
Something that I've heard from facilities I'm working with now is that the pharmacies are no longer providing the vaccine. They finally put a cutoff on it, the CVS and the Walgreens, at least here in Texas. And since the Johnson & Johnson vaccine is coming out, and they're hopeful that their in-house pharmacy will be able to stock that Johnson & Johnson vaccine. And so I don't know, Dr. Dahl or Dr. Juravich, if you have any information on that vaccine and what that should look like.
Nothing current, but Kelly, you're being from Texas. What your governor's banishing masks What's been the response to the nursing homes?
As of right now, the nursing homes are still following the same protocol, and I don't believe there will be any adjustments with the health department. But until next week, I don't know. I've been seeing the articles actually flowing through my email today as we're talking about what's next. But I would believe that they'll keep their same standards in the nursing home.
Yeah, I mean, boy, that really sets up a states versus federal rights issue going on there, because, you know, CDC and CMS expectations are is that everybody will continue to wear masks until further notified. Yeah, good gracious.
Quite the controversy down here in the South.
Dr. Jurevich, if I could just answer the question Kelly proposed regarding vaccine in North Dakota, at least. Our state government program is definitely working with local public health, with the area pharmacies and area providers for facilities to help them get new admits vaccinated, and also staff. And then also Thrifty White is a long-term care pharmacy here in North Dakota that is getting federal allotments from the government on vaccines. So they're able to assist as well. You know, it was early this week, they had lots of appointments available, and that would be a great option if, you know, you have a local Thrifty White in your area to have additional staff vaccinated. So we have lots of opportunities in North Dakota. And then the last opportunity, of course, is with these vaccines becoming more easier to handle, you know, the Pfizer, 2 weeks in the freezer and such. It would be great for facilities to apply to be a provider with the state as well. And that way, you know, going forward, because it looks like this will be with us as possibly an annual booster. So getting signed up with the state as a provider would be great as well.
Yeah, thank you for that. And then Vicki put in about hoping that the vaccinations will open up visitations. And so I think I came across the proper instructions from CDC for a proper hug. And so there was a little video about proper hugging post-vaccination, and it was just it was kind of silly. You know, you're supposed to turn your head and, you know, do the hug looking away from the person, and not to do such a robust hug or whatever. So I guess we'll get instructions on proper hugging here to come down the line. But, you know, just reflecting on that, I want to reemphasize one of the points that we made earlier in these sessions, that the value of the mask is face-to-face, front-to-front protection. And actually the most vulnerable areas for mask not failure, but not working as well is behind you, right? Because all the air, a proper fitting mask should expel the air back around your ears and to the back of your head. And so you can imagine, you know, the recommendation for doing a hug, that if you're turning your head and now the back of your head is facing the back of the head of the other person, the masks are defeating themselves. So I'm going to take a little bit of an exception. You know, I'm not sure the science is there quite yet, but you know, you got to use common sense, you know, when we look at these things. And so, like I say, the proper hug may not be so proper down the road here.